Hello and welcome back to our last lesson. In this video, I provide a brief overview of Lesson 11, Special Topics. There are so many to talk about. How do we get it done? Let's take a look. In the key summary for this lesson, I highlight take-home points from physical therapist Sally Fryer-Dietz, private practice owner and author who specializes in multisensory integration and concussion from infants to 18 years old. She provides insights into red flags to identify sensory reweighting dysfunction through behaviors and how to integrate into therapy. I add some new info to the CCVR course about aging adults, highlighting the prevalence of multifactorial balance in older adults and the role of vestibular rehab in addressing dizziness and preventing falls. As I have previously mentioned, age does not affect vestibular rehab outcomes, although it may take longer. Now, this relates to strictly vestibular impairments. Often in older adults, you have multisensory impairments due to vision impairments, weakness, pain, vestibular, maybe peripheral neuropathy. It's a multi-system approach. In the section on Parkinson's disease and vestibular rehab therapy, this was originally brought to you by physical therapist Kendall Riddell. She reviews research and brings insights into key findings in the exam and techniques we can integrate into therapy specific to this patient population. She talks about how the alpha-synuclein naturally occurs in all brains, but the clumping of these proteins is abnormally present in those with Parkinson's disease. It's also present in the vestibular nuclear complex, resulting in vestibular-related signs and symptoms in this patient population. And it's also found in the retina. Research is actually looking at this as a potential indicator for Parkinson's disease. Another topic is FND for functional neurological disorder, which is the overarching category, while FMD for functional movement disorder is a subcategory. In these patients, most diagnostic testing is normal, but we don't start by telling patients this. They don't want to hear about another test that's normal. So we focus on the findings we did find in our evaluations. We discuss this as a software issue, not a hardware problem. It's been proposed that diagnoses such as 3PD or even Parkinson's fall into these categories. Even though diagnostic testing is normal, the person can present with tremors, inability to walk, convergent spasms, tingling, visual changes, cognitive decline. We'll provide insights into these findings and some added exam techniques and treatment strategies that you can use. In treatment, we often focus on grounding techniques. Most of these patients will have an assistive device that they don't need, so we'll move them towards not using it, and it's super important to provide very clear expected outcomes. We'll look a little closer at 3PD versus MdDS. There are differences in the diagnostic criteria and treatment strategies for these two diagnoses. For 3PD, one or more symptoms of dizziness, unsteadiness, or non-spinning vertigo occur on most days for at least 3 months. Symptoms occur for prolonged periods of time, such as hours, but they may wax and wane in severity. Symptoms don't have to be present continuously throughout the entire day. And then other causes must be ruled out. For MdDS, or MdDS syndrome, the criteria include a non-spinning vertigo characterized by an oscillatory perception, such as rocking, bobbing, or swaying. It's present continuously or for most part of the day. Based on the diagnostic criteria, the onset occurs within 48 hours after exposure to passive motion, such as being on a boat or a plane, even for long distances in a car or on a train. That sounded like a little poet there. Another characteristic is symptoms temporarily reduced with exposure to passive motion, such as driving. In other words, they would prefer to be driving. They would prefer to be moving. The symptoms are persistent for more than 48 hours after the exposure. However, you will be introduced into spontaneous onset MdDS, where there's no known exposure to a passive motion to trigger these symptoms. So a big differential in 3PD is movement will make it worse. With MdDS, movement can make it better. While 3PD focuses on grounding techniques, improving the use of somatosensory and vestibular inputs, downregulating that sympathetic nervous system, MdDS treatments are often based on exposure to optokinetic stripes. There are various approaches for this. Then there's Visually-Induced Dizziness, or VID, or Visual Motion-Induced Dizziness, VMID. These are not recognized diagnoses, but are terms related to dizziness caused by visually complex environments. It is common in those with vestibular migraine, FND, and 3PD. It's not fully understood, but is commonly related to sensory reweighting dysfunction with an over-reliance on vision and an under-reliance on somatosensory and vestibular, combined with an upregulated sympathetic nervous system, fight, flight, or freeze. These patients may also have a sensitivity to noise, or basically any type of sensory stimulation. The next section of content is brought to you by Dr. Giannoli, world-renowned neurotologist who recently wrote a book on third mobile window syndromes, which he is well revered as a global subject matter expert. For this portion, however, he focuses on dizziness in the litigating patient. This may be an area that you don't think about specializing in, but if you work with this population, there will be moments when you are differentiating between exaggeration and a FMD. There is a diagnostic criteria for malingering, which is any combination of the following: a medico-legal context of the presentation, a marked discrepancy between subjective and objective findings, a lack of cooperation in testing or treatment, and associated with antisocial personality disorder. Now, the intent is not that you make this diagnosis, but you recognize the characteristics. He introduces the concept of aphysiological sway, which is a pattern you will see in many of your patients, malingering or non-malingering. If you have access to computerized posturography, you can use a formula to objectify aphysiological sway patterns. He also provides insights into documentation and clinical pearls for this patient population. We finish off this lesson with revisiting the emotional or psychological component that we see in many of our patients. Let's start with some definitions. Catastrophization is a cognitive distortion where a person assumes the worst possible outcome will happen. This can result in heightened anxiety and stress. Rumination involves repetitive and passive thinking about causes and consequences without engaging in problem-solving solutions. This is often associated with anxiety and depression. Perseveration is the repetitive continuation of a particular response, like a word, a phrase, or a gesture, and is more related to brain injury. The content in this lecture includes original content from Emily Schottman, who started as a neurooptometrist, and I've had the privilege of working with for more than 20 years. She is now a licensed psychology counselor. She combines her work as a neurooptometrist in the psychology world and is a leading expert in brain spotting. A take-home point here is considering how our central visual field is connected with our sympathetic nervous system, fight, flight, or freeze, while our periphery is connected to our parasympathetic nervous system, rest, digest, and recover. Think about your patients and how they get locked into their central visual field. They don't want to process what's in the periphery. Yet this is how visual spatial process happens. It's an integration between our central and peripheral visual fields, with the periphery being most related to movement. In this lesson, we get some ideas based on the neuroscience of brain spotting and how we can integrate it into our treatment as non-psychologists. We look at this as a turning point from post-traumatic stress into post-traumatic growth opportunities. And what a way to end the CCVR. You've been under stress, now you get to turn that into amazing opportunities. I love the CCVR course and learn something every time. We're super excited about this new launch that has a reorganization and updates of content. Okay, so you did it. You're done with the lessons. Yay and congrats. Thanks so much.